Welcome back. If you're just joining us, you're right on time because the show is just about to begin. And just as Messi said, it's a show where we discuss everything about the female child, although sometimes take exception to look at life generally in terms of health, education, welfareism, and the likes. Well, today we shall be looking at a very important and interesting topic. It has to do with you. I'm sure you relate to it. Now, it's how women contribute to national development and the health sector, particularly in relation to treating children. And we have in the studio Dr. Juliana Olufunke Lawson. Dr. Dame Lawson is a consultant pediatrician, vice chairman of Zankli Medical Center, Abuja, one of the vice project consortium partners. She's a member of the Paediatric Association of Nigeria, Nigerian Medical Association, Nigeria Society of Neonatal Medicine, fellow of the West African College of Physicians, and Abuja liaison officer for the Sickle Cell Support Society of Nigeria. She is a member of the Board of Trustees, Sickle Cell Cohort Research, SCORE Foundation, Nigeria. Apart from regular clinical practice, she has been involved in research work in rickets and sickle cell disease in the community. Well, it's good to have you in the studio. Good evening, Ma.
Good evening.
How do you do today?
I'm very well, thank you.
Well, how is life treating you? You look beautiful and amazing.
Thank you. We thank God.
Yeah. All right. It said that around 140 million babies are born every year in the world. That's the statistics. And that's more than 4 births every second of every day. Do you think Nigeria has what it takes in terms of quality healthcare for children?
Well, I would say yes, we have the people. The infrastructure may not be adequate, but we do have people, the doctors, the nurses, pharmacists, and other healthcare professionals. But the tools to work with, we may not have adequately.
So let me, sorry to cut you short. You just said the tools to work with. So how do you function when the tools to work with are not available or adequate enough?
Well, we've learned to be resilient and to be innovative in a lot of ways. So many of us work extra hours. We make do with what we have and do our best. But generally, I mean, there are some centers that do have these tools, especially in the private sector and in the tertiary centers. That's the third level of care in Nigeria. So we have many hospitals now that have high-tech instruments and equipment to help to manage the child.
Okay,
Yes.
we'll come to technology. You know, I was speaking with someone earlier, and he made mention about, he said something like, when it comes to nursing, you hear that you just know from the very back of your mind that it's a woman. So it's just more like a stereotyping that a woman ought to be a nurse and the male do not play that part. And I also asked you earlier, how is the job like? And you said, well, not everybody, it's a complex one, not everybody wants to get into it because of its nature. So how are you dealing and how are you coping? Looking at the fact you spoke about tools, it means there are no adequate tools, right? But people are available. Are people really available?
We don't have the required number of people that we need to take care of the health, but there are people around to do that. I can't say we have the adequate numbers. No, we are way, way, way below what is expected for the population. But there are people who are skilled and available to work, so they are there. But you said nursing is seen to be for females.
Yeah, not me. Well, someone said.
People believe.
Yes.
Yeah, when you think of somebody like Florence Nightingale, you know, in the 19th century, who was helping us here in Nigeria to prevent the death of twins that were being killed in the south part of Nigeria. Yes, mothers generally were more caring, we're more compassionate, we tend to take care of children. So it's expected that, oh, nurses and anything to do with taking care of the sick should be a woman. But that's not the case. We have male nurses as well, especially in areas of nursing, in orthopedics, in surgery, where you need able-bodied men to lift and to do some stuff like that. Yes, there are nurses that are male, but not so many, especially in Nigeria. In other parts of the world, you do have caregivers that are male. And in healthcare, I mean, when I went into pediatrics many years ago, there were more men than women. But presently...
What changed?
What changed indeed?
Yeah. What changed?
I really don't know. I just saw that over the years, indeed, the pediatricians, when we go for our annual conferences, we say, we are becoming endangered species in this Pediatric Association of Nigeria, because most pediatricians now are women. But growing up, I mean, we knew Professor Likoyi Ransom Kuti and many of the prominent pediatricians, they were male. But now, there are lots of female, and we have overpowered them, so to say. And there are so many of us now. But I feel that over the years, maybe men have found it easier to go for things that would get them money fast. Pediatrics doesn't pay as much, to be fair, really. They will do obstetrics, surgery, and those kind of things, operations where they'll get money. But we, being made the way we are, we tend to want to care, to, you know, be more humanitarian.
So it's more of a service to humanity.
Yes.
Okay.
So I think that's the case. And somehow, I think even parents and grandparents, when they come to the clinic, they seem happier to see a woman now. I mean, they had no choice before, but now it looks like they'd rather see a woman. Though, I mean, that's not to say that's the case, but
I get it.
You know, they feel they can communicate better. You know, now we're talking about breastfeeding. You want to show a woman how to breastfeed. You know, they feel the female doctor will be better at doing it. Exactly. You know, those kind of things.
All right, then I'd like to ask, how have women played significant role in advancing the healthcare in Nigeria?
So in Nigeria, we've had women in high places. We've had women who have been in the healthcare profession as CMDs, that's Chief Medical Directors of hospitals. They've been heads of departments. Indeed, not too long ago, we had Professor Adenike Grinch, if you remember. She was the Federal Minister of Health, you know, and she was a pediatrician, a woman. And we've had women that are running NGOs, that are making policies. We have women in the Federal Ministry of Health. We have a lot of women who have established pediatric and child care hospitals. So they are providing care to children. We have those who are representing us in various areas in the Senate. You know, quite a few female pediatricians are making waves in taking care of children. Apart from taking care of children, in research, in innovations, we've had female vice chancellors. So in the area of education about child health, we've had women as well. We've had women who are into public health, global health. So when you're talking at the international level, they're contributing by providing advocacy, policy making. So our role is not just take care of the child, but also to make sure that policies are made that will help these children to grow in the right way and not fall sick, prevent disease, you know, and if they do get ill, to provide the services needed.
Some of these ailments they get sometimes spanned from even before they were born, in terms of, let's talk about sickle cell anemia and the likes. Are there proper, does your work require perhaps orientation to parents before even in terms of having intimacy before the children coming in? So to know that you are not supposed to do this, you're not supposed to do that, if you do not want this. Does it involve that too? Oh yes, I mean, you know, it's not just giving care. We also give counseling, we give psychological support, and we try to screen. You know, so what happens is early, you have a lot of education now about sickle cell, for instance, which is one of the most serious, in fact, the most serious inherited disorder. You know, we know it's inherited from the parents. It's not from one. So you need to know your genotype way before you fall in love, before you get married, and before you have children. So we advocate
and many groups are doing that, that as early as in secondary school, they do screening. So they know their genotype before they fall in love. Because we know that if somebody who is a carrier of the sickle cell gene marries somebody who is a carrier, there's a 1 in 4 chance for every pregnancy that that woman has that she'll have a child with sickle cell.
Yeah.
And we know sickle cell is a very serious disease, though, I mean, it depends on the phenotype, how they present. But generally, it's really, really a very serious disease that causes morbidity. That's illness, it causes early death, you know, complications, you know, and a lot of economic stress for the family, psychological stress, you know, emotional stress. And so we are, as pediatricians, we need to be trained to educate mothers and fathers, and even before they get married, to educate them about the likelihood of getting sickle cell disease if 2 carriers marry, and the consequences of it.
Okay, to back up that question, like over the years, there haven't been any way or solution where the sickle cell anemia can be eradicated totally. Has there been any?
Well, when you say eradication, that would be maybe talking about something that is contagious or something that's... But when you mean, okay, no new ones will be born, that's what you mean. Because eradication means you want to get rid of
yes, because I mean, okay, if, for example, I mean, if there is a sickle cell patient, is there
a cure,
a permanent cure to
that's
it?
what you mean. Okay. Yeah. Right now, the only cure is what we call hematopoietic stem cell transplant. There is a cure.
Okay, there is a cure.
Yes. It is very, very expensive, not readily available.
Oh.
Indeed, the only center that is about to start now in Nigeria is the Sickle Cell Aid Foundation and Luth collaboration in Lagos. Okay. So the setup is there. They've promised us that very soon they'll start doing it. But many years ago, there were a few of such bone marrow transplants that were done at University of Benin with Professor Bazwai. So they had a few, but somehow along the line for several years now, we haven't had any. But in other parts of the world, they are being done every day. You know, I have quite a number of clients that have gone for bone marrow transplant. They've come back and they've done well. Because what they do is to remove the S kind of in lay terms and replace it with AA. So the genotype changes. So they are no longer having sickle cell. And there are a lot of complications. In fact, before you even have it done, you have to get somebody that is matched, usually a sibling, that you can use so that there will be less risk of rejection of this bone marrow that is being transplanted. So even getting that match is a big problem. By the time you eradicate the cells from the bone marrow, you're going to reduce the immunity of that child so that he'll be susceptible to infections and can die even in that process. Of course, he can reject the transplant, just like any other transplant, can reject it, and that can lead to complications and death.
How affordable is this transplant? Is it something that a common man can afford? Let me just
yeah, because back up to that, I have a statistics here. It says in terms of pediatric surgery, about 96.3 million children and adolescents aged 0 to 19 years reside in Nigeria, comprising 54% of the population. Without adequate access to surgery for commonly treatable diseases, many face disability and increased risks of mortality. Then now the question is, how best can this bed care remains inclusive and accessible to children, notwithstanding the circumstance or perhaps the backgrounds, because like you just described, it's expensive. Yes, I told you it's expensive, very expensive. We're talking of hundreds of thousands of dollars.
Okay.
Yes.
That was so expensive.
So for the common man, I guess it just
So that's where we keep talking about prevention, prevention. And we also talk about early detection, screening. Okay. So now we're pushing for universal newborn screening, so that immediately after the child is born, you can screen and find out if this child has sickle cell. And once you know that, you can now start doing things that will prevent that child from falling sick, and the child will be able to grow to the maximum potential. You know, before we used to hear of Ogbanje and all these funny things that, oh, the child will come after 4 months, 5 months, will die, then will come back again, the woman will get pregnant, die. Of course. At that time, we were not making the diagnosis. And most times, really, they will not die at birth. They will die when they're a bit older. It's after 6 months, usually 4 or 6 months, they start manifesting. That's the time when the fetal hemoglobin they were born with has been replaced with by the sickle cell hemoglobin. So because of that, they now fall sick. Maybe also they're introducing other foods and infection comes in, you know, and they die. So the next time they deliver another one, the child dies. So the idea is to screen very early. So once you screen, you are going to enroll them in comprehensive care. So this comprehensive care will provide things like teaching the parents proper nutrition, prevention of infection. We give them penicillin. We make sure they take their vaccinations to prevent infections, especially streptococcus, which is one of the life-threatening infections that they have. And there's a new drug called hydroxyurea. That drug actually has been found to be really remarkable in preventing infection, in preventing death, in preventing complications. So what that does is it increases their PCV, that's the level of their blood. The likelihood of getting crisis will be less, you know, and we've seen that that has been very helpful, and we have a lot of children on it. So if you don't go for comprehensive care, if you don't go to a place where you can receive this care, you may just be giving paracetamol when the child has fever, or, you know, just treating the child like any other child. But that child is not like any other child, needs specialized care. Okay,
I would want to know some other common, perhaps, illnesses that children suffer from, aside from sickle cell. We mentioned is, I don't know, jaundice part of it, or some other sicknesses that our viewers would want to know.
Okay, well, when it comes to sicknesses, you have to look at the different ages.
Okay.
Okay, in the very early part of life, shortly after they are born, the common thing will be, maybe at the time of delivery, they have what we call asphyxia. That means they do not breathe well at birth. So they have to be resuscitated. Then they may have complications, develop some brain injury, and have long-term neurological problems. Then the jaundice you mentioned can occur during the newborn period also. We call that neonatal jaundice. So with that one, there's breakdown of the red blood cells, and this is converted to bilirubin. That is the bilirubin that colors the eye and causes jaundice. And that jaundice can pass into the brain and go and cause complications. The child will start having seizures, will start having stiffness of the body, and other things. So that same child can now grow up and not meet his, get to his maximum potential, because he will not sit when the others are sitting. If it's severe, he will not even talk, he will not walk. You know, there's delay in all the milestones. You know, in a child who has what we call kernicterus, that is the severe form of the jaundice. So that's what happens with that. Then you have infection. That is very common, especially those who are born very early, that we call preterm. So prematurity is also a problem in the very young ones. You know, and then as they get older, other things will come, other forms of infection will come in. Pneumonia, that's infection in the chest. You can have malaria, which is a big problem in Nigeria up till now. But malaria vaccines are coming up, but they are not readily available. We don't even have it in Nigeria yet, you know. But you have other communicable diseases too, you know, which we call sepsis. A lot of different types of infection can occur in these children. You know, but pneumonia, malaria, sepsis generally, they are things that many children do have. And of course, you have to prevent injuries too, because sometimes they are not in safe environments, they come in with injuries, you know, so those are things we see commonly in children. Yes. Okay,
let me take you back a bit regarding the sickle cell anemia. Now, since you say the transplant is very, very way too expensive, now I know of a number of people who are carriers of this sickle cell.
Yeah.
But another time I've heard them complain that even the supplements and antibiotics that are recommended are barely available in the hospital. I am going to ask, or I would ask, how is the healthcare sector in general helping matters when it comes to making these drugs available for the people, the patients?
Okay, you mentioned carriers and then you mentioned
sickle cell anemias.
Those who have the
Yes,
disease. Okay,
yes.
sickle cell disease.
Yes.
Okay, so you see, one of our roles is to be advocates for the health of children. That is a major role as a pediatrician. So the Paediatric Association of Nigeria, the Sickle Cell Support Network of Nigeria, and many of the other groups that are advocating for care for sickle cell, we've approached different agencies. You have many people who are sponsoring the donation of drugs. We have, I belong also to the Sickle Cell Research Education Group, and we provide medications for some sickle cell patients in some teaching hospitals. So there are many groups that are providing support for people with sickle cell. But more importantly, we have discussed with the Minister of Health. We are advocates for children, so we've had discussions with them, and their policies, they are doing a good job, really, as it is now. They're very much interested in sickle cell. At the time, I mean, there wasn't much interest in sickle cell, even though Nigeria has the highest burden in the whole world of sickle cell disease. But we were not doing much. But in the last decade or two, we've had a lot of improvements in that. So it's now something that the Federal Ministry of Health is addressing, and we're having policies and guidelines on management of sickle cell. So to provide the medications, well, we are advocating that treatment for all children with sickle cell should be free.
Okay.
So it's the federal government that would have to provide that.
Okay, I would like to ask, in terms of early intervention and preventive care, because you said it's very important when you're talking about the care for children. So how much cooperation do you get from parents?
Well, I think the main thing is education. If you educate them, they would go with you.
But so far, you've been in the field. Do you
Oh
get
yes,
as much
oh yes,
cooperation?
oh yes,
Yeah.
I do. You know, because initially, of course, there are these myths and beliefs that there was a time they would say, if a child is convulsing, put the foot inside fire. You heard that before. Or a child is not eating, you press the head and force feed that child. You know, they were doing all those at a time, but all that is stopped from education. You know, and I think when you explain to people and give them the reasons why they should do or not do something, they tend to follow it if they know it's for the good of the child. Because as long as the child is ill, they are not feeling well themselves. So there's a lot of cooperation, especially with mothers. They are ready to do anything. Even when they are ill, they always forget about their own illnesses and just concentrate on the child. So, you know, they will cooperate with you if you explain, but not just, oh, they come in and say, see, madam, give this to your child, you know, and you haven't told her why she should give that to the child. So if you are the type that would tell them, oh, see, it's because this child didn't have this kind of nutrients, that's why he's developing this kwashiorkor. So you advise them, this is the food you give, you know, try it out, come back, you know, follow-up is also important. And when they come back, they see the difference. Of course, they're going to be happy and they're going to listen to you. And you continue to get their cooperation.
All my viewers, we'll go on a short break. When we return, Engender continues. Stay with us.
Welcome back. This is still the Engender Show on KAFTAN Television, and we are reaching you live from the nation's capital, Abuja. Well, before we went on that short break, we are discussing about sickle cell and some other ailments and diseases. And also a gentle reminder that, of course, I know some of you, a lot of you must have been watching, and since we have someone special in the studio today, you might want to ask 1 or 2 questions. This is a reminder that our phone lines are now open for you to call in to give in your contribution or ask a question. All right, now let's talk about motherhood and breastfeeding. Well, I don't know how true this is, but our parents would say that if you're not intelligent, it's a generational curse. So why in this generation we are told that there are actually some nutrients that helps the brain function and all that. So please take us through that. Talking about exclusive, I know when I had my first daughter, my mother-in-law never allowed. She said, no, you cannot do that in my house. There is we are in dry season. You only do exclusive during the rainy season.
What does that mean?
So please, I want you to talk us through that part.
I mean, this is really topical because from the 1st to the 7th of August is the World Breastfeeding Week.
Okay.
So it's good that you are bringing up this topic. Breastfeeding is best for the baby.
Okay.
If you feed a baby with human milk, the baby behaves like a human being.
What happens in a situation where where let's say we know the phase which Nigeria in now, things are hard. People could even afford meals. You talk more of nutritious meal. I mean balanced diet. What happens to those who are able to afford balanced diet? I mean properly balanced diet.
You are talking of the mother. Okay.
Yes, the mothers, of course.
Okay. So, well, since you've started with that, a baby, when it comes to breastfeeding, is a parasite.
Okay.
Oh, yes. The baby will get everything he or she needs from the mother. Yes, a few nutrients may not be adequate, but those will be most likely the micronutrients, maybe vitamin D, if the woman doesn't have enough, a few of those kind of things. But generally, we've seen in Somalia, when there was war and famine in the land, you see big fat babies on skinny, very skinny mothers. The baby will still take what he or she needs because it's a process of stimulation when it comes to breastfeeding. As the baby is sucking, it's releasing some hormones. The hormone is telling the brain produce milk. So whether the mother has or not, the milk will be produced. It's the suckling that initiates that breastfeeding. It's not the weight of the mother or any of that. Of course, if she's severely malnourished, there are some nutrients that the baby will not get.
Okay.
But generally, at least the baby will try and get what he or she needs from the mother.
Okay, so do you advise that this is applicable to both people in the rural area? I mean, inside village, like inside, because compared to people who feed well, who are able to, you know, who are able to afford good balanced diet and who are
those in the rural areas, they feed very well.
They feed well. They get even.
But it's just that most times they really do not breastfeed. Rather, at a very tender age for the child, they give the children maybe semo, pap. You see a small child eating food that Messi can eat.
No, that's why we educate them. In the first 6 months, breast milk is adequate for the baby. That's why we talk about exclusive breastfeeding. It is adequate. It has enough macronutrients. It has enough water. It has the micronutrients. It's protective. It has a lot of antibodies that will protect against infection. It is at the right temperature, in the right form. You don't need to go and look for electricity to charge a kettle to get water. There's even no money to buy milk. Milk is going for
13,000
all those formula. I don't know how much, you know.
All right, let's take this caller. Hello. Thanks for joining us on the show. Please, what's your name and where you're calling us from?
My name is Liberty. I'm calling from Abuja.
All right, Liberty. Let's get your take on the program.
Okay. I think that. Can you hear me?
Yes, please. Can you turn down the volume of your TV set? Or
Okay, let me do that. Let me do that immediately. Is that good now?
Yes.
Yeah. So, I think that my take on this is that, as you can see, there's also a kind of conspiracy theory among the ruling elite that people are sponsoring this protest.
Okay.
But I think the conversation. Hello.
I'm sorry. I had to cut the call because it's not the right program for that discussion. Okay, so we are talking about breastfeeding. Breastfeeding.
Yes. So
okay.
I said it's at the right temperature. You don't need any preparation. It is sterile. You don't need to, you know, do anything but just carry your baby, wash your hands, clean your breast, and give the baby. You know, from the first day. And the more the baby sucks, the more the milk comes. So it's not that it's going to dry up because the baby is sucking. The sucking itself is the stimulation for production. So we advocate that within the first 6 months, exclusive breastfeeding. After that, you can add all this MO and the other things you have mentioned. But even those ones, you need to add protein and other things to it. You know, but you find out in the first 6 months, our babies are big, they are healthy. In the village, in town, wherever it is, they are doing very well.
So are you saying those formula might not be necessary if you breastfeed your child?
They are not necessary, not might, at all.
And yet people spend so much on them.
I don't know why they buy them. I don't know why they buy them. The other thing you mentioned about brain growth, I was talking to you about human baby, human milk for human baby, cow milk for cow baby. Yes, there's a lot of technology now. They've added some things that appear like human milk. Human amino acids and all those things. But the breast milk is the one that has the human oligosaccharides that are necessary for the brain growth. The first year of life is the most important time for brain growth. At that time, the brain weight doubles in size. And by the time the child is 3 years old, he has most of his brain cells already formed.
Okay.
In fact, over 80% are formed by 3 years. So if you miss out during this time that these cells are being formed, you don't give the child the nutrients that will allow the brain to grow, then performance will be a problem.
Women, mothers often complain that they are drained, they are tired. Perhaps they want to sleep at night. The child is awake, wants to suck. And I have a friend currently who suffers same fate. She's totally tired, exhausted.
And most of them have this complaint that the baby sucks a lot. So in most cases, the breast milk is not enough for the baby.
She says it can never run dry.
Sucking doesn't prevent it from.
But I've heard people say it doesn't come out. The milk does not come out.
Like I told you, we talk about exclusive breastfeeding. So that means within 30 minutes to 1 hour of delivery, that baby must be put to breast. It is critical. But many times, babies are born. The mother wants to sleep. They say she should go and have her bath. People are visiting her. She must drink.
She's not supposed to. That was a whole lot of work and stress. That's a journey from.
She first take kunu, then she will take pepper soup before
palm wine. I used to take palm wine.
They will take all this before even feeding the baby. No, in fact, what is done is at the delivery room, the baby is put to breast. Start sucking. The colostrum, that's the yellow, thick yellow one that comes out, is high in nutrients.
Okay.
Very high in nutrients, high in antibodies, prevention of infection. So once the child starts taking that, that's all the child needs.
But what happens when I had my first child?
It didn't come early.
It didn't come early. Yes. Even after hours, I had to wait for an uncle to go and get palm wine. I had to drink palm wine. So what was the cause why in cases where after hours and like you mentioned, there was no breast milk?
It won't even come early. It's rare for it to come. That when I say
is the baby going to starve?
He's not going to starve. That's what I'm explaining to you. You see, God is wonderful. That colostrum, we call it, that yellow, thick yellow one, even 2 drops of it contains more than 1 ml of the yellow, white one. So the little that child would see, you will not see it. The baby is sucking. You are not going to see it because it's not much and he's taking it in. But it has enough calories to keep that baby until the whitish one starts coming out. So that is all the baby needs. The baby is just coming out from the mother who has already given some nutrients to the baby. And most times they still have some kind of store with them. A baby hasn't starved to death because the breast milk didn't come. It doesn't happen. The baby will get what he needs. So that's what I'm trying to say. They need to start early, do it frequently. You see, but the problem is mothers get frustrated by 24 hours when they see they're not seeing that milk flowing the way they want. They say, this child is not getting anything. They will starve. They will do this. They start bringing bottle. And once you introduce the bottle, there's nipple confusion, first of all, especially for a mother who has small nipple. And you are now giving the bottle feed where the teeth is long and it's convenient. The child will just keep taking that one and refuse your breast milk. That's what will happen. And then when you don't position the baby properly, you know, there's what we call latching on. That latching on is critical because there's a position you have to put that the baby will now suck the nipple and part of the areola. not just the nipple. Because if he keeps pulling the nipple, there's pain, nipple will crack, the mother will be tired and say, I don't want to breastfeed. And we need family and community support. That's why we keep saying, when a woman is breastfeeding, she needs all the support. She doesn't have to enter the kitchen. She doesn't have to go and start taking care of the other children. No. She should have that support. We are saying exclusive breastfeeding. So, Father, you're not buying milk now. That is 15,000 per bottle. Give that money to her. Let her
eat well.
Eat well. Let her buy what she wants. You understand? So, there's nothing like, okay, I'll quickly breastfeed. I'll go and cook for my husband. He will soon be home. No. At least in the first few months, let this woman get her strength back. Let her initiate breastfeeding, because that initiation is the important thing. So that when it's flowing and flowing and flowing, then at that time, of course, she can be doing other things and breastfeeding. But those first few weeks are critical.
Let me ask, in this Gen Z generation that we are, in this Gen Z, I've come across a lot of people who say that when they, including their husband backing up, that the wife would not breastfeed the child, that they would rather use milk. Why? Reason is because he doesn't want his wife's breast to sag. You understand? So does it have any impact, or does it have any harmful or negative impact in the child if the child does not suck the mother's breast? And again, those that their mother died at birth and they had to live on milk, is there some persons will say, in my I am an Igbo, and in my place they used to refer to those ones that they are senseless because they did not get from their mother. Exactly, they did not breastfeed from their mother. How true is that? Like, is there any sense in it?
Now, about the sagging of the breast.
Yes.
It's not the case. We are all made differently. There are people who have breastfed 4 children. They take off their blouses and you will not believe it. When you are breastfeeding, you support your breast. You support your breast. You make sure you take care of yourself. It's not that you just lie down. How can one support? You wear the proper bras. You wear the proper bra. You don't just let your breast down. And with time, really, it will still go down, whether you breastfeed or you do not breastfeed, because the fat is going to start going down. As you get older, there's not as much fat around there. So with time, it will still go down. It won't sag like, flat like we used to see in the old times, because those mothers at that time, they were not wearing bras, they were not supporting. They'll just go around, once the baby is ready, fling it back, drink the thing and move, But if you take proper care of your breast, it shouldn't be an issue. Sagging is not an issue.
Okay, still talking about breast. Okay, maybe
the second part, you were talking about
kids that did not breastfeed.
Kids that did not breastfeed. But you see, at a time, we had a tradition that if a mother died at birth, the aunt or even the grandmother who is still lactating would feed.
Yes.
That was happening.
But it doesn't happen today.
Now it's not happening. But you see, we have what we call breast banks, breast milk banks. I don't want to go into that because it's a bit complicated.
Okay.
But there's a way you can bank milk. That's the people that are producing breast milk would express. You freeze the breast milk and you can feed the baby with the breast milk for months. You can keep it in the freezer for a long time. When the baby is ready, just
bring it out. Is that healthy enough?
Yes.
Okay.
It is healthy. Abroad, it is pasteurized. When you take it from people that you don't know because of HIV hepatitis, they have pasteurized milk. But you can, even a mother who is lactating well, even if she's not and she has the time, can keep express. After feeding the baby, express, put in the freezer. After feeding, express, put in the freezer. So that when you are going to work, you bring out like 3 bottles. There are packs they usually have. Bring out like 3 packs or whatever. Keep it in the fridge. When it's time to feed the baby, it would have thought, you just bring out one of it. Whoever is at home will give the baby. So you can actually store breast milk and use it when you need.
Okay, to add to what you said, recently I saw a woman who has a child, already breastfeeding her own child. Then she brought her sister's child who was in the hospital for an ailment, I think fibroid at the time. She had just put birth to the child. So she took up the task of breastfeeding the child herself. So I was surprised, like, you're breastfeeding your sister's child. I said,
well, that's a good thing.
breastfeeding her. So yes, I believe one can also take up that responsibility. So I would like to ask, when is the right time to stop breastfeeding? Because I know some people say, no, don't stop breastfeeding your child at the age of 1 year. No, stop at after 6 months. Some say 2 years or so what's
that
the
you
best
have
time?
sharp brain.
And what method should one? I know when I think I've seen some women use bitter leaf. What method can a mother use to stop her child from breastfeeding?
The thing about breastfeeding is that it's not only the child that is having the benefits, the mother. You know, once you start, if you start early enough, the uterus will start contracting early. So you have your tummy flat very early. The uterus goes back to the right size. Then it helps you psychologically. You are bonding with the baby.
Okay.
Maybe that makes them breastfeed for long. Apart from that, it's been known to protect from ovarian cancer, from even breast cancer. Those who breastfeed are less likely to have those cancers. So the mother may want to continue because she knows there are many other benefits. I'm just telling you a few of that. But what we've said is that after 6 months, that exclusive breastfeeding is not enough for the child.
Okay.
So at 6 months, you are going to get locally available food. You know, we have the way they make what we call kwash pap. It has soya beans, crayfish, corn, millet, tom brown, all those kind of things. You can make your semo, light semo with okra soup, ewedu, you know, because the draw soup, they're able to easily take it. They take it well, you know. Some will say they want to give Cerelac and many of these other cereals. Fine if you want to, but really we have food in Nigeria that you can prepare for babies. So as they grow older, from the mashed ones to solid, they take all that. At the same time, you continue to breastfeed. So we say breastfeed until 18 months to 24 months.
18 months to 24 months.
Yes. So, but during this time, breast milk is not the real, you know, at that time, the child will go and play, come back and take breast milk. But most times we say breastfeed until about 18 to 24 months. But importantly, complementary feeds, appropriate ones must be given to the child. I see people who breastfeed till 4 years even. Yes. And on the lighter side, on the lighter side, yes. No, well, on the lighter side, there is a woman I saw recently. Somebody forwarded it to me where she said she was breastfeeding her husband. You know, and people were shocked that how can you breastfeed your husband? But of course, she had weaned the child off the breast, and she continued because as long as you stimulate the breast, the milk will keep coming. Okay. So if you are stimulating for breastfeeding, it will keep coming. You know, but
all right. I want us to still go back to the child care. I'm sure perhaps you've cared for children in your own ways, or you're just perhaps in terms of policies and the rest. But notwithstanding, what challenges have you faced so far, and how were you able to overcome them?
Okay. The main thing is that I said initially before the program started that when you are taking care of a child, you are taking care of the whole family. You know, the child will come with the auntie, the grandmother, the mother, the father. So you need to calm the anxiety. I think that's the major thing. You know, those people that come around, they tend to put a lot of pressure on you. So you need to calm them. So from the beginning, anything you are doing, you are relating it to them, telling them this is why this child is doing this. This is what I want to do next. This is what you'll expect. You know, and of course, more importantly, the child cannot even tell you what is wrong most times. If it's a young child, you as a professional, you'd have to use your knowledge to know exactly what is wrong. And children don't pretend. Once they are getting better, you will see it. Once you are doing the right thing, you'll be saying, isn't this the same child that I saw that was just lying down and couldn't move earlier? So you have to be able to discern the signs of sickness and improvement. So the challenge is knowing what exactly is wrong with this child. A child comes to you, the child is screaming from the door, just screaming. But as a pediatrician, you have to check, okay, what is causing this child's discomfort? It could be something as simple as a tight outfit. It could be, at the time we were using safety pin, I had seen mothers that the safety pin had opened from the nappy and was causing discomfort for the child. And the child was screaming. All we did was remove it, and the baby was okay. It could be hard stool. This child is trying to poo-poo, and he just, and then he starts screaming because he can't get it out. It could be something more sinister, like an ear infection. You know, when they have ear infection, they are uncomfortable, they are screaming, you know. So there are things you look at. For something that is really bad, most times there will be a fever. But it could be even as something that he has picked up and aspirated. He's uncomfortable, you know. So there you look at, oh, the way this child is breathing, something has gone into the chest. That's why he's breathing like that. So those are the challenges. They cannot tell you what is wrong with them most times when they're young. And you, as a professional, you have to find out. So you have to examine every system in a child that is not doing well and help the others around. And then,
okay. Yeah, I wanted to point out that most children suffer from teething when they begin to grow teeth. Like, perhaps help us, how can a mother deal with this kind of a situation?
Let me add to that question. I have seen children, I mean infants, as tender as a year plus and 2 years, within this range, let me say, become very aggressive. When I say very aggressive, you just sit back, and most times I've asked and I was told, some persons said, you know, in Africa we have different beliefs. Some persons say it's a generational whatever, and some persons say no, it's some like a health challenge. You see a child of 1 year plus or 2 years become very aggressive, that he or she picks up something and break, destructive and all that. What is there a health challenge that's causing that?
Okay, so let me come to the teething. Teething occurs usually, the starting is about 6 months. You see, this is a critical period. 6 months, for many reasons, is one, the time when the antibodies that the baby had when he was inside the womb and when breastfeeding exclusively will start to wane. So it's susceptible to infection. It's the time when you are introducing new foods to the child, you know. So you are the one preparing it. Maybe you keep it and it can be infected or contaminated. Then this is also a time when the gums are itchy. So you see the child touching different places. He had just started crawling. He's also picking things, putting in the mouth. And some people will even give them teether, in quotes. They are putting it on their gums. They are scratching. In the process, they're introducing infection. Then they drool a lot of saliva. And as they are drooling, some of it is going into the throat. You know, they can develop even chest infections from too much of that, or aspirate some of it. So there are many things going on at 6 months. So they call it teething. Yes, in quotes, it's teething, but there's other things causing it that will make the child go down. So at this time, you want to make sure everything around that child is done in a hygienic way.
So is it possible for a child not to experience any?
I have 3 grown-up children. My last child is 34. I have 7 grandchildren. None of them has had what we call teething. I don't know what it is.
Okay.
I haven't had any situation where I would say, okay, the child is teething. Yes, the teeth will come out. Oh, well, for them, many of them didn't have teeth until they were like 9 months.
But some usually stool, run temperature and all that.
They may have a bit of temperature. Okay. The stooling could be because there's a lot of drooling. So as they are drooling saliva, they're also passing it in the poo. So they do have some symptoms, but the main thing is if the body is hot, there's no other thing, it's not more than 38 degrees, just give paracetamol, comfort the child, make sure you are close to the child, prevent him from picking things and putting in the mouth, because the thing is they tend to pick things and put in the mouth. They are crawling, the hands are dirty, the next thing they put that hand in the mouth. You know, it's usually infection around that time that causes the diarrhea, the fever and all the things that they have. So you have to protect them from all this. You know, and that's what you try to tell them. Because some people will just say, he's teething, just leave the child. But the child has developed an infection. He needs to be seen. He needs to be rehydrated if he's having diarrhea. He needs to be given antibiotics if there's infection. And that's the time the immunity is down. They can have malaria for the first time at 6 months also. So a lot of things are going on from that 6 to 9 months when they're having their first teeth. So you just need to educate mothers. Concerning this child, Well, there are many reasons why a child would do that, but the more common one would be a child who is on the spectrum of autism or attention deficit hyperactivity disorder, where you have neurodivergent children who, maybe because he cannot speak and express himself, will be annoyed and throwing things and getting upset. You know, it is common amongst them. They have delayed speech. They have sensitivity to sound and some other things, so they get irritated. That's possible, but it's not to do with any generational cause. Yes.
Not the mate. All right, thank you, man. Our guest in the studio has been Dr. Juliana Olufunke Lawson. It's been a pleasure having you on the show. It's almost an hour already.
Yes. Wow. Yeah. And it feels like we should just go on and on.
Yes, so much question unasked, but I'm sure maybe when next we'll call on you, you'll be here for us. Here. All right, viewers, that's the much you can take on the show this evening. It's been a beautiful ride. I've learned a lot, especially for the teaching part, because I see so many children suffer from it, and I just thought maybe it's natural. Every child has to think it's natural suffer from it.
You have a child?
Yes, I have.
Did he have the teething problem?
Yes, they both did. Yeah. Fever, stooling.
And I never experienced any of that with any of my children.
That is the first time I'm hearing it, because those days, even my mother-in-law and my mom will all tell me that it is natural, just like my colleague said.
I've said it's a time when the immunity is down, so they are susceptible to that.
All right, viewers, I'm sure you've learned one or two. For me, I have. Now, I'll be very careful when I put to bed. My child won't experience it. Well, I am Victoria Agbi-Idoko.
Well, at this point, this is where we'll draw the curtain for today's episode on the Engendered Show. And so far, if there's anything I've learned, it's been a wonderful ride. It's a proper hygiene can go a long way to help you. And for those of you out there, please make sure you adhere to 6 months exclusive breastfeeding. And of course, that's where we leave it today on the Engendered Show. Like I said earlier, keep watching KAFTAN television until we come your way some other time. I am Missy Emelite. Do have a great evening. Bye.